Welcome to this Win Club online module on Incontinence-Associated Dermatitis or IAD, which forms part of a series of modules you can access to develop your knowledge and understanding around wound management and skincare. Today, we will be discussing Incontinence-Associated Dermatitis, which I will be referring to as IAD for the duration of this session. By the end of the module, you will be able to define and describe IAD, be able to discuss the treatment and management of IAD, and also distinguish the difference between IAD and pressure ulcers. IAD is a type of moisture-associated skin damage, or MASD. Now, MASD is an umbrella term for the 4 types of skin damage caused by moisture. It is also defined as the inflammation and erosion of the skin caused by prolonged exposure to various sources of moisture, and that includes urine or stool, perspiration, wound exudate, mucus, or saliva. Now, MASD has got 4 distinct conditions, each having a slightly different etiologies, namely, number 1 is Incontinence-Associated Dermatitis, which I will be expanding for the duration of this session, Intertriginous Dermatitis, Peri-wound moisture-associated dermatitis, and peristomal irritant contact dermatitis. Now, it is important to distinguish between the 4 conditions to ensure appropriate management. For more information around the 4 types or different types of MASD, be sure to complete the Wound Club online module on MASD. Okay, let's focus on IAD. Now, IAD is defined as an erythema, an inflammation of the skin caused by prolonged contact with the skin of urine and feces. It typically presents as an inflammation of the skin surface, characterized by redness and, in some cases, swelling and blister formation. There are many different terms to describe IAD. Now, perhaps you have heard a few which are on your screen now, for example, moisture lesions or nappy rash. Now, having these different terms can cause or make it very difficult to determine how many people suffers from IAD, as well as ensuring standardized method of care is used to treat IAD. Under the new pressure ulcer definition and measurement recommendation from NHS Improvement in 2018 here in the UK, all skin damage caused by moisture should be classed and reported under the umbrella term of moisture-associated skin damage, thereby making the use of these other terminologies, the one that you can see on the screen now, questionable when it comes to reporting skin damage. So, who is at risk of developing IAD? Now, in short, any patient who suffers from incontinence is at risk of developing IAD, so including patients with urinary, fecal, and double incontinence. There are also a number of risk factors which can put a patient at risk of developing incontinence, and therefore making them at risk of IAD, including poor skin condition, compromised mobility, and side effects from medications. Now, a continence assessment will help determine the problem and what treatment is required. Therefore, it is important to establish a comprehensive baseline continence assessment, as its outcome will inform correct diagnosis and treatment. Many organizations have developed their own unique assessment criteria, so please check with your local guidelines. However, on your screen now are some of the risk factors for IAD that you must consider. I'll give you a few seconds to have a look. As discussed earlier, IAD is caused by prolonged contact with the skin of urine or feces. Let me explain this in more detail. Now, when the skin is exposed to urine for a prolonged period, bacteria convert the urea found in urine into ammonia, which is an alkaline substance, which increases the skin pH, rendering the skin more vulnerable to colonization with bacteria and secondary infection. Now, in addition to this, the digestive enzymes contained in feces are reactivated in an alkaline environment, therefore damaging the skin's natural protection, which is the acid mantle. A damaged acid mantle means fluid from urine and feces are drawn into the superficial layer of the skin, causing its cells to swell as they become overhydrated and subsequently disrupting its structure, thereby causing erythema, inflammation, sometimes skin erosion, which are a typical characteristic of an IAD. The skin exposure to a combination of urine and feces, the combined effects of these processes can significantly increase the risk of IAD development compared with exposure to either urine and feces in isolation. Let us now look at some specific characteristics of IAD. Now, normally, IAD appears as diffuse area of erythema, scaling of the skin, blister formation may also occur, and it may present as an open with weeping skin damage. It is typically shallow or superficial. Edges are irregular, diffuse, and you may also observe maceration or whitening of the skin. They are commonly found on the perineum, skin folds, between the buttocks and down the inner thighs. In your process of assessment, your patient may also report burning sensation, itching, and pain from the affected areas. Evidence relating to MASD classification is limited. There is the Ghent Global IAD categorization tool, which provides alphanumeric categories and subcategories to describe the extent of skin damage. And the tool was very specific to one type of MASD, which is the IAD category. UK practitioners suggested that this tool has similarity to the pressure ulcer classification system, and utilizing this for IAD classification may cause confusion when documenting the extent of skin damage. This confusion may become more apparent following the 2018 NHS improvement recommendations that clinicians should report MASD as well as pressure ulcers of category 2 and above. Now, the National Association of Tissue Viability Nurses in Scotland have developed a useful excoriation grading tool for IAD to help clinicians adopt a consistent and accurate approach in the assessment and management of patients with IAD. This classification tool or table that you can see on your screen now is an adaptation. It offers a simple categorization terminology regarding the extent of moisture damage using the term mild, moderate, or severe. And these also include a healthy skin category. Each category offers a clear definition as to what constitutes that level of damage and skin type. Before we go into the treatment and management of IAD, we need to look into the differentiation between IAD and pressure ulcers. Although both these wound types can be closely linked, the management and treatment of them is completely different. It is often difficult for clinicians to correctly identify an IAD and to distinguish it from pressure ulcers. But the key point to note is that if the patient is not incontinent, the condition is not an IAD. Under the umbrella term of MASD, the classification is down to the source of moisture as the principal etiology or the cause of damage. For example, IAD is caused by urine and or liquid feces, whereas peri-wound moisture-associated dermatitis is caused by wound exudate. To find out more about the different types of MASD, be sure to check out the MASD Wound Club online module. IAD and pressure ulcers have a number of common risk factors. Both are likely to occur in patients with underlying poor health condition and restricted mobility. However, there are distinct differences between the two. It is important to recognize the difference between the two, as different interventions will be needed to manage them. Furthermore, IAD has a different etiologies from pressure ulcers, but the two can coexist. Now, IAD is a top-down injury where the damage is initiated in the surface of the skin. Now, conversely, pressure ulcers develop when damage is initiated by changes in the soft tissue below and within the skin, and it is therefore coined as a bottom-up injury. So remember, IAD, a top-down injury, a pressure ulcer is a bottom-up injury. Now, moisture-associated skin damage, and IAD as an example, should be counted unreported in addition to pressure ulcers. However, in cases where skin damage is caused by a combination of moisture and pressure, it must be reported based on the category of pressure damage. This table from Beekman in 2015 presents the key differences between IAD and pressure ulcers across a range of parameters. The first parameter is around the history of the wound. Is the patient incontinent? Have the patient been exposed to pressure or moisture? It is about determining wound etiology or wound cause. The symptoms can be different. The patient will feel pain across both wound types, but may have additional sensations like burning sensation, itching, or tingling if the wound is an IAD. The location of the wound can also provide some information around whether the wound is an IAD or a pressure ulcer, along with the shape of the wound. Pressure ulcers tend to have a distinct edges or margins, whereas IAD tends to have a poorly defined edges and may be blotchy. In summary, it is essential that you assess accurately the cause of skin damage to allow correct diagnosis and treatment. For example, to prevent pressure damage, the most important factor is to reduce or relieve the pressure. And to prevent moisture damage, the most important factor is keeping the skin clean, dry, and well hydrated. I am sure you will agree with me when I say that these are very different management options. Okay, let's now focus on the treatment and prevention of IAD. The following precautions can help reduce the risk. Minimize skin exposure to urine and stool. Manage incontinence. And for persistent cases, catheter or fecal containment devices may be needed. And consider strategies that will reduce friction forces. You can apply skin barrier creams and reduce friction forces to protect the skin from further damage. But please ensure that all patients with urinary and fecal incontinence should have their skin assessed at least once daily, depending on the number of incontinent episodes. And remember, change continence pads and products promptly when indicated, and include your patients in decisions about their care if it is appropriate. You must also consider a consistent regime of skincare to protect the integrity of the skin, including cleansing, moisturizing, and use of skin protectant, and avoid frequent cleansing with soap and water. I will be discussing both strategies in more details next. To prevent and manage an IAD, there are two key interventions which are critical. So number one, manage incontinence to reduce or ideally eliminate skin contact from urine and or feces. Now, as I mentioned earlier, you can do this by promptly changing pads and incontinent products when indicated, or either considering catheter or fecal containment devices for persistent cases of urinary and fecal incontinence. Number two is implement a structured skincare regime to protect the skin from exposure to urine and or feces and help restore the effective skin barrier function. A structured skincare regime consists of two key interventions: cleaning the skin to remove any sources of irritants which cause IAD, and protecting the skin to avoid or minimize exposure to bodily waste and friction. You can do this by using appropriate skin barrier cream. Prevention of IAD should be aimed at all incontinent patients with the aim of promoting positive outcomes and avoidance of patient injury and harm. And again, if it is appropriate, please include your patients in decisions about their care. An example of a skincare regime can be seen on the screen now. You must also avoid frequent cleansing with standard soap and water, as this is detrimental to the skin barrier function. Standard soap is alkaline, which can change the skin's pH and open up the skin to damage from other factors such as friction and shear. Instead, a skin cleanser with a pH range similar to that of a normal skin is preferred to avoid any further skin breakdown. Foam plus spray cleanser in particular contain a surfactant that removes soiling with minimal forces, allowing healthcare professionals to avoid aggressive cleansing technique using washcloth, which can further abrade the skin. Let us now go into more detail on those key interventions. Minimizing the skin's exposure to urine and stool means removal of irritants promptly, using the right products and applying it correctly. Cleansing the skin should be done prior to the application of skin protectant as part of a routine process to remove urine and feces. When using skin cleanser or a pH-neutral soap with water, take care not to cause further damage through skin stripping by aggressively rubbing the fragile skin or damaged skin. It is a known fact that gentle use of cleansers and skin protectants decreases the incidence of IAD. After cleansing, the skin should be protected from moisture. Skin protectants, also known as moisture barriers, can come in creams, ointments, paste, lotions, and films, and can be applied directly to the affected skin. And when you're looking for an effective protectant for the prevention and management of IAD, you should consider the following key characteristics: the ability of the product to form an occlusive layer, increasing skin hydration; the transparency after application to allow skin inspection, and remember, you must perform a skin assessment at least daily; the ability of the product to not affect incontinent pad absorbency to allow effective continence management; and if the product can be safely applied on an at-risk and damaged skin relating to moisture. Well done you! You have now completed the Wound Club online module on Incontinence-Associated Dermatitis. To check your knowledge and understanding, try and answer the following questions. We are now at the end of the module. Take the time to reflect on how you will take some of what you've learned and apply it into your daily practice. It might be useful to think of some patients in your care and reflect on their skincare and how you might manage this going forward. If you are on the NMC register, then please click on the link description below to access a copy of the revalidation form, which allows for deeper reflection. Adding this reflection will mean that you will be able to claim extra CPD minutes. Thank you for your time today. Please remember to look at the other sections of the Smith+Nephew channel to access additional modules to help you on your learning journey.